All right, let's talk about nephrolithiasis. You probably know them better as kidney stones. Today, we're going to do a high-yield explainer breaking down everything from that infamous pain all the way to how you can keep them from coming back. Let's get right into it. So anyone who's had a kidney stone or even just knows someone who has, they all say the same thing. It's all about the pain. I mean, its reputation is legendary, right? But what's actually going on in your body that can cause something so intense? It really all boils down to tiny little crystals forming where they shouldn't. So let's start with the thing that brings pretty much everyone to the doctor, renal colic. And trust me, this isn't just a bad stomach ache. It's a very specific, very dramatic set of symptoms that tells a very clear story. Now, what's really key on this slide is how all these symptoms come together. The pain is the headliner, no doubt. It's this severe, sharp pain in your side or back, and it comes in these waves as the stone is trying to move. But here's the real clinical clue, the thing that screams kidney stone: the restlessness. You see, with most pain, you want to curl up and stay still. With renal colic, patients literally can't sit still. They're pacing, they're shifting, they just can't get comfortable. That, plus the nausea and the sweating, it's just a classic picture. Okay, so what are these little things causing all this chaos? Well, a stone is not just a stone. They aren't all created equal. There are actually four main types, and figuring out which one you have is the absolute key to preventing the next one. Yeah, just take a look at this breakdown. It's not even a close race. The overwhelming majority, we're talking around 80% of all stones, are calcium-based. After that, you've got struvite stones, which are often called infection stones, making up about 10 to 15%. Then come uric acid stones at 5 to 10%. And finally, the really rare one, cysteine stones, at just 1 or 2%, which are caused by a genetic condition. Let's break down the two most common ones that aren't tied to infection. For calcium stones, the big problem is hypercalciuria, which is just a fancy way of saying there's too much calcium in the urine. But just as important is having too little citrate. Think of citrate as your body's natural stone preventer. It binds to calcium and stops crystals from clumping together. Now, for uric acid stones, it's a totally different story. The main villain here is pH. When your urine is just too acidic, classically a pH below 5.5, the uric acid just can't stay dissolved. It falls out and forms crystals. Simple as that. Now, for the other two, struvite stones are kind of wild because they're directly caused by certain types of bacteria, like Proteus, that produce an enzyme called urease. This actually makes the urine more alkaline, and these stones can grow incredibly fast. They can form these massive staghorn calculi that look a bit like a deer's antlers, filling up the whole kidney. On the other end of the spectrum, you have cysteine stones. These are purely genetic. It's a defect where the body can't process an amino acid called cysteine. For doctors, the dead giveaway is finding these perfect little hexagonal crystals when they look at the urine under a microscope. So if you're a med student studying for a test, or you just want the one thing to burn into your brain, this is it. This is the ranking you have to know. Calcium stones are king, way out in front. Then you've got struvite and uric acid, which are roughly in the same ballpark. And then way at the end, the rare one is cysteine. This order is how doctors start thinking about the problem from the get-go. Okay, so you've got the symptoms, you suspect a stone. What happens next? Let's walk through the diagnostic process and see how doctors go from suspicion to confirmed diagnosis. You know, the approach is really logical and stepwise. It all starts with the story, the patient's history, and those classic symptoms we talked about. Next, a simple urinalysis to check for blood, look at that all-important pH, and see if there's an infection. Then comes the imaging, so we can actually find the stone and see how big it is. And finally, and this is so important for the future, analyzing the stone itself once it's out. Now, when it comes to imaging, this is really important. You can't use the same test for everyone. For most adults, the gold standard, the absolute best test, is a non-contrast CT scan. It's just incredibly good at finding stones. But, and this is a huge but, for pregnant patients, avoiding radiation is the top priority. So for them, the first and best test is always an ultrasound. It's a critical difference. The diagnosis is in. It's a stone. The pain is real. Now what? How do we deal with it in the moment? This is all about acute management. So, before we even talk about specific treatments, we have to talk about size. And this number, 5 millimeters, is a really big deal. Why? Because stones that are 5 millimeters or smaller have a really good chance of passing all on their own with just a little help. As soon as you get bigger than that, the odds of it getting stuck start to go up pretty fast.
So the game plan for an acute attack starts with step one, which is non-negotiable pain control. That means anti-inflammatories, maybe opioids if needed. Next is hydration. And then there's something called medical expulsive therapy. This is where you use a drug like tamsulosin, which is an alpha blocker that helps relax the ureter, that little tube the stone's trying to get through, to make the passage easier. And if all of that doesn't work, or if the stone is just too big, then it's time for a procedure to go in and get it.
Look, getting through one kidney stone is a huge relief, but the real goal is making sure you never have to do it again. So, let's open up the prevention playbook. If you take away only one thing today, please let it be this: the single most effective strategy for preventing almost every kind of kidney stone is high fluid intake. And the goal isn't just to drink more water, it's to produce more urine, at least 2 liters a day. It's all about dilution. You're just flushing everything out before it has a chance to form a stone. This is the foundation of all prevention, period.
Beyond just hydration, the strategies get a lot more targeted. For those super common calcium stones, a thiazide diuretic can help lower the calcium in your urine, or potassium citrate can boost those protective citrate levels. For uric acid stones, remember that pH problem? The fix is to make the urine less acidic. For struvite stones, it's all about getting rid of those specific UTIs. And for the rare cystine stones, it's a combination of aggressive hydration and also making the urine less acidic.
And really, this is the whole point. You can't run the right play if you don't know what game you're playing. A one-size-fits-all approach to prevention just plain doesn't work. That's why catching that stone and getting analyzed is so critical. Knowing your stone type is what empowers you and your doctor to make a plan that actually works.
So, there it is. We've walked through the pain, the 4 main culprits, the diagnostic journey, and the game plan for treatment and prevention. You have the playbook. The only question left is, what's your plan to stay ahead of the game and prevent that next stone?